Hi everyone, I am Ellie Morrison. I'm your host for today's webinar and another one of the series of ABLE webinars. Today we are marking International Harm Reduction Day. I think I will get started. We're a couple of minutes past 12 and I'd like to acknowledge the traditional custodians of the lands on which we're all meeting today. I'm on the lands of the Wurundjeri people in Naarm in Melbourne, and these lands have never been ceded. And drug policies and the war on people who use drugs has had a massive effect on Aboriginal and Torres Strait Islander people in this country, as well as First Nations peoples in other parts of the world. So, a bit of housekeeping as well before we start. This session is being recorded. We're going to have a Q&A at the end, but you can put your questions into the Q&A section of this of the site at any time, and we will try and get back to you with the answers when we have them, as well as ask those questions of the panelists at the end. There's also some closed captions in English for those people who would like to use them. And so I'm going to get started. So this is International Harm Reduction Day. I think there's a lot of days in the calendar, and ABLE looks at a lot of those, and we choose the ones that we want to celebrate or mark. And for us, I think International Harm Reduction Day is a bit of a new one. It's a bit of a slightly different one in the calendar that we haven't had until fairly recently, but like I am absolutely aware of how important harm reduction is for our community and for me personally. I think it's like 40 years, 41 years since we've had harm reduction in Australia, and it's made such a big difference for us in this country. So on that note, I do also want to acknowledge the people that have worked in harm reduction and the peers, especially that have used harm reduction services and provided harm reduction services and informed our policies and regulations and made the difference for our community. Like we are the reason that we have no huge HIV epidemic among people who inject drugs. We're the reason that we have such a good hepatitis C response. There's still work to be done though, and that's why it's still important to keep talking about this topic. So I have the pleasure of doing the first presentation today. We've got an amazing group of all peers as our panelists, and that's for me, that's pretty awesome as well. We have such amazing people in this country able to provide expertise on a range of topics. So you'll be hearing about some of those today. That we can't cover everything, but that's why we have a webinar series. But we have like people from some of our member organisations across the states and territories in Australia. We're really fortunate at the moment to have member organisations in every state and territory of Australia. We haven't had that for a long time. And like that's a sign, I think, of how we're growing and strengthening all the time. And for us at ABLE, we've also restarted some international work, which is what I'm going to talk about, just to highlight, I guess, how lucky we are here with what we've got and why it is so important to keep fighting for our peers here and in other countries. So I'm going to start sharing my screen. Someone just give me a thumbs up to let me know if it's working. Is it? Great. Thanks, guys. Okay, so I am talking about the Angels Collective, and this is some work that ABLE is leading in Fiji. Uh, oh, okay, so Fiji has the world's fastest growing HIV epidemic. It's a huge national crisis for the country. In 2024, there were 1,583 new reported HIV cases. That's a 12-fold increase since 2018, and that's just the people who are accessing HIV treatment. A lot of people are not getting tested or are not able to get treatment or are not accessing treatment. And the crisis, the HIV epidemic in Fiji is affecting people who inject drugs more than anyone else. So 48% of those people who are getting treatment are people who inject drugs. And we all know how hard it is for people who inject drugs to access the kinds of services that will out them as people who inject drugs. So the 48% like tells you something is pretty serious for those people. And it's estimated that by the end of this year, another 10,000 people will be living with HIV. So it's been declared a national emergency, and there's attempts to engage with populations like the groups of our community, people who inject drugs, as well as sex workers and other people. And for us, that's meant some work that we've been doing over the last year because the drug that's being injected most in Fiji is methamphetamine, and there's incredible levels of stigma. Obviously, we know that's the case here as well. But there's also incredible levels of stigma about HIV and misinformation or a lack of awareness about what it means. It's pretty new for people in Fiji to have methamphetamine in and injecting drug use. It's really only been the last 5 years that there's been more people that are injecting and using methamphetamine, that it's been available in the streets. So the knowledge, even among the people who are injecting, about safer injecting and about bloodborne virus transmission is really low. People don't necessarily know that sharing a syringe can transmit viruses like this. And there's efforts to get needle syringe programs in Fiji, but those efforts have not succeeded yet. So we're still waiting on that to happen. In the meantime, it's harder for people to get syringes from pharmacies. So before there was a lot of public knowledge and all the stigma that's kind of come from that about the methamphetamine use, people were actually able to get syringes from pharmacies if they had the money for it, but most pharmacies will not sell them anymore because the police are cracking down on pharmacies, trying to, solve the crisis in the ways that police sometimes do when they don't know about harm reduction and stuff. So there's no drug user organization, there's no NSP, it's hard to get syringes, and there's low knowledge about what this means for people, but a lot of media attention and things that make it harder for people to actually be out and safe. And so knowing these things, we began working with a group of people who we trained, 15 peer educators, so people with living experience of injecting drugs. We trained them last October in Suva, and we talked about safer injecting and blood awareness, HIV, hepatitis C. We did a pretty intensive week with this group of people, and we didn't actually have enough money at the time to employ all 15 of them. And we thought, like an intensive week of training, like some people are going to drop out, but none of them did. So we had to find some more money because they were all amazing. And we'd been incredibly lucky to be able to find people from different backgrounds, because a lot of the injecting drug use is happening in the transgender community and in the sex worker community, among gay men as well as straight men and women. So we had that mix of people in that group, and there was no one that we thought we didn't want to employ. And somehow we managed to find some of that money to employ them all to do 12 hours of outreach work each week. And we worked with them on how you do that, and have continued to support them since then. Originally, we were funded by DFAT, and that money ended. It was meant to be a short-term project that would then lead to the NSP starting in Fiji, and these people would be like perfect to employ as peer educators in the NSP, but the NSP hasn't started and they're still needed. So we're in phase two now, and we've managed to get some private funding to be able to keep this program going and maybe expand it a little bit. And in that first few months of work that they've done in 22 weeks, they've had more than 5,000 occasions of service. They average seeing 255 people a week, and they've reached 3,417 new people. So new people just in Suva who've had education about HIV and safer injecting. And they've reached, the youngest person they've actually reached was 11. So one of the things about injecting in Fiji is that there are some really young people injecting in really unsafe ways. And the diversity of the people they've reached that is the same, is similar to their own diversity. So they've reached those young people, but also men, women, transgender people, gay and straight people. We've given them a lot of flexibility because, they've got that local knowledge, and so they are identifying the types of people that they want to try and reach. So some people are focusing on clients of sex workers. Some people are focusing on the drivers that are driving trucks and other things and that are using methamphetamine. And I think that's been really important and quite a unique part of this program is that they've been able to have some autonomy about how they do it. So they've also given 85% of the people that they've reached blood awareness education. So people who had no idea that that blood in your syringe can transmit HIV to someone else. 87% have had safer injecting education, and 89% had safer drug use education. Oh, that's not good. Oh, sorry. More than 3,000 have also had HIV testing information, so that's about 31%, and 3,500 condoms were distributed. So for like 15 people, or sometimes it might be 12 or 13 people, working 12 hours a week each, that's pretty incredible when nothing like this program had ever existed before. There was no outreach like this in Fiji, and this continues to be the only project in Fiji that's focused on injecting drug use, and it's run by peers. It's like it blows me away how amazing they are. And we all know why peer education is important, that you reach people where they're at, you can reach people that other people can't reach. You can talk to people's family and friends and reduce stigma in the community. And I think the way that these guys have gone out into their own communities in Suva and talked to so many different kinds of people and continued to do it with this almost 300 people every week just shows how important the work is, and how much it's needed in this community. And when they talk to us about the work they're doing, they tell us how much people appreciate it as well, that they tell the peers how inspired they are by them and how they didn't know these things and feel, they want to know about safer using especially. In the words of some of our peers, these are the kinds of things that they've talked to us about, how important it is for them to be a part of the program and how important it is for them to give back to their communities, and, be a part of this response to HIV in Fiji. And it's for me, it's just been incredible as well to be able to work with them. So that is a little snapshot of the work that Able is doing in Fiji and that we hope to continue doing. And truly I think one of the most amazing groups of people doing the most amazing work in the world at the moment. So with that, I will go back to our panelists. Uh, and my running sheet. Bear with me a moment. Okay, so from Fiji, we're going to return to another an Australian program. So Emily Ebden is our next speaker, and Emily's the president of the Tasmanian Users Health and Support League. She also works full-time for Able on the Hep C campaign as a Hep C campaign and capacity lead. And she has 20 years experience working in frontline harm reduction and contributing globally, nationally, and locally. She's a proud narco-feminist and she has a special interest in gendered harm reduction and drug policy. And she has been a key part of the reason why Australia now has drug user organisations in every state and territory. So over to you, Emily.
Oh, that's very generous of you, but thank you for that introduction. I've got slides too, so I'll just get my slides ready. Oops. Can you see my screen? No. How's that? Cool, thanks everyone. First I'd like to start by doing a special community acknowledgement for Tussel's outgoing Vice President, Kerry Dow. So Kerry died last year in August after a 6-month battle with terminal cancer. She was a a fierce peer leader, one of the foundational members who in Tussel's current reincarnation. And I don't know what else to say. Just that basically she never resigned from the Tussle board. She was an active board member till the day she died in true Kerry fashion, and I just wanted to highlight her today. Just a quick slide for context. As Ellen pointed out, 42 years since the AIDS crisis in Australia, and we've celebrated 40 years of harm reduction policy in Australia just last year. This is the time, like there's a great quote from Annie Madden, Dr. Annie Madden, who says, with the dawn of the 1980s, Australia's injecting drug user community became increasingly aware of the unfolding threat posed by HIV. So that's kind of the era that all the Australia's drug use organisations sort of sprung into existence to respond to that threat. And I can't help but notice that's often the case with innovation around harm reduction. It comes under in an urgent situation. And Tussle, it's our first incarnation, started in the same era as all our sister drug user orgs. I just wanted to point that out. Also, it's so interesting to look back at the history to know that Abel's first meeting was held in Hobart for a national AIDS conference in 1991. Oh, sorry, I think it was actually 1990. So we've always had a little connection, you know. Just a quick map to show that each state and territory does have a drug user org, like Elle was saying. ABLE also has members, Students for Sensible Drug Policy, and we also have input as an international drug using peak. Here's a little timeline of Tussle. So I'm going to have to move you guys around. So, as I said, in 1990, TUCA, Tasmanian User Community Advocacy Association, was formed, auspiced by the Tasmanian AIDS Council, now TASCARD, and they actually had a peer NSP worker employed at the Tasmanian AIDS Council. So that's kind of Tassie's first official formal harm reduction peer worker. In 1992, TUG, Tasmanian Users Group, is formed and coexists with TUCA. And then in 1996, Tussle comes into being as an unincorporated organisation auspiced by Your Place Incorporated. Continued offering harm reduction services through primary and SP of peer workers, and small amounts of funding were provided for one-off pilot projects. I would note too that Tussle does not to this day have operational funding, despite this timeline and in all its incarnations, there's never been a properly funded and supported drug use organisation. Despite all this work from 1998, it continues, and the year 2000. Then in 2012 and to 2018, I was actually originally part of that board in 2012. Yeah, and it was just the same thing, I can tell you, just the lack of resources. It's not from lack of passion or knowledge or amazing peers. I feel like we've just remained a fledgling org because of those lack of resources and proper support through funding. 2024 is what I was talking about before. That's when a new board formed, and with the support of AVIL mainly, and also with the blessing of the previous long-standing president, Mark Jones. So why did Tussle reform? Again, in 2024, it was really to respond to the threat of a toxic, unregulated drug supply. So as users, we often incur these situations as they're happening live. So we were aware that there were the sleepy meth was happening. There was some boosted heroin. We were aware of anecdotally a lot of overdoses happening, and basically we just wanted to do something. So this is harm reduction kind of at its finest, grassroots, popping up. We've got social media now, we can distribute these messages of drug alerts with very little funding and money. So yeah, this is really the catalyst for why Tussle reformed. So what's different about Tussle with the other DUOs? We don't have funding, the operational funding. The second point used to say we were decentralised and we were doing all our services outreach. Well, that's slightly changed because Tussle now has an office in Hobart. However, it's attached to a co-working space, so it's not suitable at the moment to deliver services from this site. So all our services are still done via outreach. We're also set up as a peak organisation, so we can accept members, individual peers as members, but allied orgs could also join Tussle as a member. And the balance of power there is that one org would get one vote compared to one individual peer who has one vote. And that's just because we're trying to get more support for Tussle in this era, and maybe that's a way of doing it. We really want to I feel like Tussle now has a really strong culture of wanting to partner with other orgs and collaborate. So it's just sort of made sense. We launched properly, I guess you would say, post-AIDS crisis and post-COVID, or at least this incarnation. We're a baby drug user org. And Tussle is formed in 2024 to respond to the drug overdoses and toxic drug supply in Tassie. This gives you some look of our current structure. So we have a board of directors. We have built into that 2 non-peer expert positions. They're non-voting positions, but we get to benefit from their expertise. One of those people is a registered nurse, and another is actually Dr. Ramondo Bruno, who you may know. He's at UTAS and has done a lot for our community locally and nationally with his research and work into the IDRS, EDRS, and also on a Tasmanian level, the syringe filters, the wheel filters. So credit to him. And yeah, we love to have those guys on the board. Um, in relation to our drug alerts, we have built a drug alert expert advisory group, and that includes myself as Tussle and also the statewide NSP coordinator with DHHS, as that person has a lot of channels through the NSPs, but also is a great way to get information to the NSPs. We have Dr. Ramondo again from UTAS. We have Dr. Amy Peacock from NDARC. And yeah, that's me as Tussle rep. We also have a really impressive dance safe program developing, and they've been doing amazing. We have a coordinator overseeing that. She's unreal. And a team of 7, and it seems to be growing. They're doing amazing work in that space. We're really proud of that program. And we have also It's Your Right Tussle Harm Reduction peer workers now. We have Nick, you might know Nick in the south. And we have amazing Maz in Launceston and Ben, who's awesome too, and he's in Devonport. We're so lucky to have them and be able to pay them through the It's Your Right money. The It's Your Right funding we received is the biggest amount of funding Tussle has ever received in its whole history. And it's really helping us thrive at the moment and build on that. And then we have people that just volunteer that are peers, and we have Tussle members, peers, and allied organisations. These are the services we offer. Sorry, I just got to move the screen. Peer-based harm reduction education and training, community drug alerts. And by the way, that yellow messaging pigeon is our logo for those alerts. So if you look out for that, you will see like that's the drug alert. Communication support. I do a lot of Tussle's comms. I'm also part of the AVIL comms team. So, and I'm a peer. So if someone wants something done by a peer for their service, for example, previously the Hep C nurses we're working with in the offer the free community testing. Prior to It's Right, they wanted a flyer that would reach peers, so they wanted a peer designing it. So I was able to do that, and that really helped us form a really nice partnership, and we love those guys to this day. And April stigma discrimination training, I was actually fortunate to be a part of the someone like the original cohort that got trained in 2012 by Able, the trainer. And even though Tussle didn't exist at the time, there was sort of a special consideration. I was working at Anglicare that as a peer working in the needle syringe program at the time, I could deliver that training. But if I left Anglicare, I could take it with me because only a peer could deliver it. So I've now brought it back to Tussle, which is just so nice to be able to do that. So we can offer that too. And with these services, because we don't have funding, we ask for donations sometimes. And I've received such generous donations for putting the puzzle together training, which has funded our activities, which is such a good little income stream. Festival harm reduction, as I said before, our Dance Safe program. We've got the It's Your Right program happening with our peer workers teaming up with nurses to provide peer support. And then we also do peer-based harm reduction and BBV education programs in the Risdon Prison Complex. We've done a 6-week prison program in men's minimum Rombarwick prison. Me and Nick just finished doing a 6-week program with the women in Mary Hutchinson's women prison, and we're about to start at RPC in the men's medium max. And we've recently just secured a secondary NSP contract, so we can distribute that equipment discreetly at events and so on, but also via outreach and also the post. I just wanted to put a few little photos in of some other activities that aren't captured here. So Kerry, you can see there a nice picture of her and some photos of her. She led an amazing project the year before she died, and she didn't even know she had cancer, where she approached Anglicare saying in Glenorchy, she wanted to, they had a memorial rose bush for people who had died of drug overdose in Tasmania. She approached Anglicare, partnering with Anglicare as Tussle to see if she could expand that rosebush and develop a memorial garden for Tasmanians who have died for drug overdose. Kerry has landscaping experience. She was a professional florist. She's an artist. It was a creative project. She did such a stunning job, and I love to honour that work here because now we have a memorial garden for Tasmanians who died of overdose thanks to her. She led the whole project, I should also mention. And what else is there? Just some photos of community events we've done, like in the middle there, we went to New Norfolk to support some flats that had a situation with inappropriately disposed of sharps, had a barbecue, met some of the people there and supported them to get the sharps safely disposed of. And also we got in an abstract accepted at the Borough Hepatitis 2025 for our work in prison in Tasmania. And that's the poster. And then just this highlights our contribution to some national projects. We've got the AVIL's National Harm Reduction Peer Workforce Framework Working Group, which we were a part of, which was a massive privilege, something I was so passionate about. It was great to feed into that piece of work as Tussle. The Prompt Response Network and Anecdotal Reporting Systems. We're part of the AVIL's National Research Strategy meetings. We delivered the UNSW Stigma Indicators Monitoring Research Project, which was actually the first time that long-standing study has been able to capture Tasmanian data because they needed DUO or peers to assist in collecting the data. And because Tussle hasn't existed before and there was no suitable vehicle, if you like, to get that data, Tussle has done it for the first time. So now there's Tasmanian representation in that study for the first time. And we received a small amount of money for doing that. And that has also added to our activity funds and so on and so forth. And also we're involved in the AVIL's National Support Don't Punish campaign. This little image here, that illustrated quote that says, "I would not suffer in pain," is actually Kerry's quote from last year for the national campaign. And also Tussle has done really well with AVIL's PACE exhibition, which is a catalogue exhibition. We have a couple of images there. Shazzy, the artist with the spoons, she got such great exposure from PACE that her art was purchased, I think it was by Harm Reduction International, to put on one of their international reports. So yeah, amazing. And thank you. That's my presentation.
Thanks, Emily. That was amazing. So it's incredible to see what a small group of people have done without core funding in Tassie.
Yes,
Like,
thanks.
and yeah, you guys have done so much, and it hasn't even been that long that you've achieved all of those things.
Yeah, thanks so. And I really can't overstate the support of AVIL in this reaffirmation because like I get to support Tussle in my AVIL role a little bit, which is in kind support. I should mention that John is on our board because none of us have got governance experience prior to this, so he's helping mentor us that way, and just being able to lean on the AVIL team has just been like the most support we've had. Not to mention just the welcome from our sister drug user organisations and the AVIL network. Like me and Carrie and Joe, when we first started going to AVIL summits, were just overwhelmed, like with, wow, we're with our people, finally. And everyone was so excited. Like, I think of Isha especially. We always saw her as like our biggest cheerleader. So thank you everyone for welcoming us and making us feel part of the AVIL family.
It's a testament to the to what grassroots peers can do, huh? Like we have
Yeah,
such an amazing network.
so true, Elle. No, thank you.
Thanks, Emily. So I think there's a few questions and comments in the Q&A section. We'll get to those at the end, but just to remind everyone that you can post your questions at any time. Just go to the Q&A section and put it in there. You might get an answer earlier on, but we'll also ask the panelists later. We're going to move on to our next speaker, another part of the ABLE team. Yvonne Samuel has led ABLE's It's Your Right National Hepatitis C Prison campaign. So she is going to talk a bit more about the innovation that's happening in our custodial settings in Australia. Yvonne also has over a decade of peer-led harm reduction experience, including a range of diverse roles working with people engaged in the correctional and prison system. She advocates for social justice approaches that challenge incarceration as a response to drug use and centres the health and human rights of people who use drugs. So, Yvonne, I'll get you to turn your camera on and start sharing your screen.
Mhm. Okay. And I need to turn my little head off. Okay. Hi, everybody. My name's Yvonne. I just want to apologize in advance. Might be a bit of death by PowerPoint. So we're looking at national innovation in custodial settings. And I think we need to start with the elephant in the room. There is absolutely no needle and syringe program in any prison in Australia. And this has come out of the fact Jeffrey Pearce, he was 21, was stabbed with a needle in Long Bay in New South Wales, and he died in 1997, and he was a correctional officer. And this has just kind of hardened or solidified the union's position on needle and syringe program in prison. It's seen as dangerous to staff, and they're not prepared to budge at this point in time. So that means people in prison are at greater risk of hepatitis C than the general community, and they remain a priority population for the 2030 hepatitis C elimination target. So they say that it's between 8 to 10% of people in prison have got hepatitis C RNA infection compared to the general population, which is 1%. And they believe that somewhere between 30 to 40% of prisoners have been exposed to the virus and have antibodies. And the fact that there is no needle and syringe program actually breaches international law, the Mandela Rule, which was created in 2015, which says prisoners should enjoy the same standards of healthcare that are available in the community. And harm reduction is healthcare. It's not just doctors. It's part of our healthcare system, and that's supported by the professional medical Australian Medical Association, sorry, who also say the same thing. Prisons, however, are about supply reduction, not harm reduction. So harm minimization has demand reduction, supply reduction, and harm reduction. And prisons are part of the supply reduction along with police and watch houses and that kind of stuff. So the percentage of funding to supply reduction is 60 to 65% of all government spending, while demand reduction is somewhere between 30 to 35%, which is our treatments and rehabs, and harm reduction is left with a piddly 1.5 to 2%. Okay. Okay, so what are DUOs doing? So we are part of the 1.5 to 2% of the funding in harm reduction. And despite the fact that prisons are a space for supply reduction, we've been allowed in and we're doing a range of work, the DUOs, the various drug user representative organisations around Australia, with people who are in prison. So in the last 12 months, we've been running It's Your Right 2. It's the second iteration, but this one actually included going into the prisons. So there's been a range of different projects that have run. We've had education and or testing being done in prisons in South Australia, in WA, in Tasmania, and in New South Wales. WA saw, I believe, over 70 people at an expo. Tussle, Emily's just told you about the work they're doing in prison. South Australia's been working with this since August 2025. And Newer got to go into Silver Waters prison and do something about closing the gap. It's also being delivered in post-custodial settings. So both NTARG and Newer took it to emergency housing where people were being placed on release from prison, and managed to capture quite a large number of people who had been just recently released. There are ongoing hepatitis C harm reduction and transition education sessions that are run on an ongoing basis in around Australia. So Quinn has a transition program that they run with QCS. Tussle's already explained theirs. South Australia has, sorry, things are popping up on my screen. South Australia has a testing and peer harm reduction education, and Newer gets invited into prisons on sporadic basis. Quinn also has a transition worker and an Aboriginal transition worker to help with hepatitis C. Anybody who starts treatment in prison, to ensure that they are then able to complete their treatment in the community, it's being facilitated by these two workers. Newer has Insiders News, which is a magazine that's distributed to New South Wales prisons, which involves harm reduction and hepatitis C information and the bloodborne virus. Karma was actively involved in the needle and syringe program pilot that nearly was implemented at the Alexander Marconi Centre in ACT. We got so close to a needle and syringe program happening, and the union vetoed it at the end. Whilst Harm Reduction Victoria does See No More, which is a bus where they park themselves, 40 metres from a correctional community corrections, and has a peer who goes in and just lets people know that they can come and have Hep C testing. And Quinn has historically run point of care testing at community corrections. And I think what we continue to do as DUOs is address that harm reduction is not meeting the equivalent of the community standards, and challenging the war on drugs, which systemically locks people up for using drugs when there's more alternative humane models that are available, such as rehabilitation. So the prisons, despite the fact that their supply reduction, are doing a range of things, although it's not perfect and it's not particularly transparent. So there is other models of peer support programs going on in prison, which are using people who are already incarcerated to share knowledge around harm reduction and bloodborne viruses. Opiate treatment program is available around Australia, but it's fast becoming Buvidol in a lot of places, although not exclusively. It's seen as preventing diversion, but also seen as an overdose prevention tool when transitioning back into the community. But there's access issues. There's caps on how many people can have the opiate treatment programs. There's wait times to get on the program. And sometimes in some states, you're not eligible if you weren't already prescribed in the community. New South Wales and Victoria have Fincol and bleach, but feedback from people who've been in prison is they don't want to go and be seen to collect the Fincol or the bleach, because then they're going to be seen to be assumed to be injecting drugs, and their cells might get ramped. So they might find their cells being tossed, searching for drugs and paraphernalia. There's bloodborne virus testing on admission. That seems to be pretty standard. There is at times in transition, and upon request varies a little bit depending on the system. There's hepatitis C testing blitzes that occur. There was the Kirby project, which was testing as prevention, that was run in New South Wales. And there's also been some outbreaks. There was an outbreak in the ACT and in Queensland, and a lot of that's done in-house or by the hepatitis C councils. Some prisons claim to have detox. Again, people in prison or who have been in prison report that you just got to cope in your cell. And there was the awful case of Veronica Nelson, who died after having complications of opioid withdrawal. Uh, they buzzed the buzzer 30 to 40 times and nobody came. And she passed away the next day. Naloxone's available to go into exit bags, and some states they have it administered by staff. And you'd think condoms would be like standard by now, but they're not even available in Queensland, but are generally available in most other places. And access to PrEP and PEP is limited due to lack of education. So we can say there is no equivalent harm reduction in prisons. And so we're not currently meeting human rights standards, which is kind of a miserable place to leave it at, but we did actually got stuff happening. So that's good. Yeah, that's all.
Thanks a lot. Yeah. Leaving on a slightly low note, but it's true. I think a lot of people are frustrated by harm reduction in prison correction settings in Australia, and that is definitely a focus for a lot of people of something that we need to improve. So it's great what you're doing and trying to get word out to that there's other things that also need to be done.
Thank you.
Thanks for that. All right, so our next speaker, I think, needs almost no introduction. Dr. Tim Pakowski is a peer researcher at the University of Queensland, and I think he's pretty much known by a lot of people as one of the foremost experts in image and performance enhancing drugs in the country. So I'm very fortunate to have Tim here to talk about the work that he's been doing and its impact for our community. Thanks, Tim.
Thanks, Al. Hi, everyone. Thanks for having me. I did take the liberty of making some slides to speak to. Um, where, how's that? Cool. Um, so, little, I guess, different change of topic. I'm here to talk about injectable synthetic peptides, and was really, really happy, I guess, to be able to put this on the agenda because we know that people who use drugs are diverse communities, and not one person can represent every single, I guess, sub community that there is. And I certainly don't intend to stand here and say, I represent everyone in this community, but I think as someone who's used injectable synthetic peptides in the past, and has seen what's been happening recently and spoken to the AVIL network and obviously all our brother and sister DUOs, it's really, really, I guess, an emerging issue that deserves some attention. And you probably would have seen media and other things. So I guess just to put us all on the same page, peptides are short chains of proteins like amino acids, and they're the building blocks. They act as chemical messengers in our body, and actually play a role in a lot of processes. But that's not really what we're talking about when we hear all this peptides chat online, or in the media or wherever else. These are synthetic and injectable, usually subcutaneous, so into any sort of body fat, but usually around the belly button's a good spot. And they're designed to mimic, but usually more so enhance processes that are going on in the body. So, for example, you probably would have heard of growth promoting peptides like CJC1295 or ipamorelin. Um, the idea here is that rather than just injecting human growth hormone, which is fantastic for your hair, skin, nails, dropping body fat, staying lean, getting muscular, this is sort of promoting the release of that human growth hormone. So a further downstream effect of what you're using. And so by doing that and by I guess not being a direct replacement, um, these have become a lot more palatable than other enhancement drugs like steroids, or even injecting like other peptides like human growth hormone or like insulin, like growth factor 1. And so I think part of the excitement and issue here is that, these are seen as, I guess, less harmful and easier step into enhancement, but also sold as, I guess, longevity, beauty, youthfulness cure. Um, and so I guess the other issue that I'll touch on is why they're so easy to access and why there's been such a huge uptake. In terms of like the actual size of this issue, I mean, we know from global data that about 3.3% of people use image and performance enhancing drugs. And I've actually been recording in many, many of the different pieces of work that I do, the number of people who use these drugs, use injectable peptides. Like a lot of these aren't new. I used BPC 157 back in 2012. I used GHRP, like growth hormone releasing peptides, in 2013. Uh, so, yeah, even though there's some new ones, like this isn't necessarily like invented this year or anything like that. Just, I guess, from one of the surveys that I conducted and published out on with some colleagues, we know that high proportions of people who use image and performance enhancing drugs use peptides. So just here, like out of the types of iPads that people used, and this was an international sample of men who use iPads. So about half of them use peptides or peptide related substances, like HGH, like ipamorelin, etc., etc. So this is like regular sort of staple product in an existing community. I think the motivations for this are as diverse as other iPads, and that is, we have people chasing aesthetics, so that beautification, general well-being, performance, youthfulness, improvements in mental health, improvements in sleep, and we see it everywhere online. And as soon as I work with anyone and we start talking about this topic and they jump in Instagram or any social, they come back and message me like a few hours later and say, you messed up my algo. Like this is all I see every day now. Um, and so it's really, really prolific. I don't know of any other substance where I can post a video online injecting it. I can't even, you can't even punch a bong online without having some sort of like issue happen. But there's plenty of people injecting synthetic peptides in their car and then putting that video up along with an affiliate link and use my discount code for 20%. And then, you're able to get these shipped to your door within a very, very short period of time. And the reason for that is that, I guess, well, there's a few, but I guess the one that I really want to focus on today is the fact that there's this real unregulated gray area here. So we have medical peptides, and you've probably heard of them. Things like GLP-1s, like Ozempic, so semaglutide or tirzepatide. We also have other research type peptides, and you would have heard of possibly this one as well, retrutide. Um, and then we have, a bunch of other, peptides that just aren't even on regulators' radars, both in Australia and internationally. Or they might be, but there's no actual concerted response. So what people tend to do is, I guess, if you want to use a regulated peptide and know exactly what it is and what you're using, that's fantastic. But you need to have a reason to get that prescription. So be diabetic in the case of Ozempic, and it's actually going to sting you. And if you're using it off label for weight loss, which is quite popular as well now, you're actually going to cop up to 500 a month, sometimes more, sometimes a little bit less. You can go online, and here's just one price list that I asked a mate to send me the other day, and get semaglutide at a fraction of that price, and then get the sterile equipment from your local NSP, and just start using it. You can find advice online or in those videos that I just spoke to you about, and it's a lot more affordable for a lot of people. Unfortunately, though, when people market these products, they'll put up these testing reports from testing facilities that I guess market themselves around this, Genomic Analytical being one of them. What we don't know is, and people like resellers, vendors, whoever will post these up. What we don't know is that actual report. Like there are numbers and there is a like chain of custody process there, but all of this is privately motivated. Unlike, for example, Roid check. So you don't actually know and can't guarantee what's happened in that process, and whether there's any other motivations there. People doctor these reports all the time as well and post them up. And there's plenty of other examples when people have been caught out or have run a test on one batch of product and then run another test on another, and it's been completely different. And labs fluctuate, underground labs fluctuate all the time. So unfortunately, and that's just one example of one type of peptide right now, but there's a whole bunch of other unapproved synthetic classes, like I mentioned BPC before, where at least for Australia, our regulator is really struggling. So TGA might have issued a safety notice recently, you would have seen in April, but BPC, which I mentioned I was using in 2012, was only regulated as a Schedule 4 poison in 2023. So if you look at that lag time, and that's just one example, and there's at least, 20 popular injectables on the market right now, there's a bit of a problem there. So the core risks, I guess, that I see for people is that unregulated peptides might be mislabeled, contaminated, incorrectly dosed. We know that from Roid check, years of Roid check research. The other critical one is that peptides, like the growth promoters I spoke about earlier, actually stimulate a bunch of unintended biological processes. And so unintended tumor growth is one of the ones that comes from GH and growth hormone and insulin, like growth factor 1 going up. That's further amplified by the fact that a lot of enhancement drugs are contaminated with toxic metals, again, as Roid check showed. And so I guess you're potentiating that even further. And then you've got a whole group of new injectors entering the market. We've got injecting that carries its risks. These aren't people that are exposed to BBV prevention necessarily. They're getting their information online in communities that don't see themselves as drug users. And this exposes people to infections, abscesses, and tissue damage. One thing that's really interesting is that, and we're seeing this in Queensland, but I've spoken to all of our DUO friends who are seeing it as well all over Australia is that we're seeing an influx of people coming to NSPs asking for equipment for peptides. And so, at least on the Gold Coast, we've seen an 800% increase from this year to last year in terms of occasions of service related to people chasing peptide equipment. And so, I guess from a both a research hat and my community hat, we're looking at how we can manage this and promote harm reduction in Australia and beyond. And I think there's three particular levers that we're interested in. And one is looking at those digital supply pathways a little bit more carefully and how those influencer market systems are, I guess, targeting particular groups. I think we need to look at health literacy interventions around body image and around, what people do with these 99% purity claims. And then we need a concerted harm reduction and clinical responses around workforce training, service readiness, peptide specific guidance. Like at Steroid Connect, we get over 4 calls a day about peptides. And I know that there's a lot more out there. And we need some structured monitoring and referral pathways. I've probably spoken too much, but I'll be happy to chat and answer questions later. Thank you.
That was incredibly interesting, Tim. Thanks so much. I always learn a lot from you, and I like the way you're also able to bring it back to some of the things that are the same about us, and that while also acknowledging we're such a diverse community of people with different kinds of experiences, and that we need to be uh, understanding and inclusive of all those different things in our work. So I think it's important for everyone and there's a lot of appetite to learn more about your area of expertise, especially with the people using NSPs more and more for these drugs. So thank you. Thank you for always being so generous with your time and your knowledge. We're moving on from something that I guess affects often a lot of young people, not just young people, but a lot of young people. And we're moving to the other side of things with our next speaker. We're going to be talking about those of us who are aging in our community and some of our needs, especially around pharmacotherapy. But our first speaker will be Chris Goff, another part of our community who needs no introduction. Chris Goff is the Executive Director of the Canberra Alliance for Harm Minimisation and Advocacy. I'm going to introduce him anyway, right? That's Canberra's peer-based drug user organisation, and Chris has also been actively involved with ABLE for a long time. He's the treasurer at the moment of our board, and he identifies as a person who uses drugs. So, have I got you there, Chris?
Yes, thanks, Elle. I'll just share my screen. Can you guys see that? Yep, sweet. All right, I'm just going to go quickly through some of these slides. I'm going to set myself a timer so I don't over blabber because we're running a bit late. Okay, I'd like to acknowledge the traditional, oh, hang on. How do I? Yes, I'd like to acknowledge the traditional owners of the land on which I'm coming to you from, the land of the Ngunnawal people, and pay respect to elders past and present, and just acknowledge that this land was never ceded and always was and always will be Aboriginal land. The funders of this are the ACT Government, ACT Health, and Community Services Directorate, and the Healthy and Creative Aging Project was funded through the Capital Health Network, which is the primary health network of the ACT. So I'll just talk a little bit about the peer treatment support service, which is our individual care program, our one-on-one care. And so really it's just like case management, but with that added peer support element. So if you think about like a complex case management, but with hope, identity, solidarity, role modeling, and that kind of innate understanding of navigating health systems and drug and alcohol systems kind of built in as a really core part, identifying goals that are important to the person, and then sequencing and stepping through those goals. That's what we're talking about. And then what I'll do is I'll just talk about how we, so how we, so we got some funding to do some aged care work, and really the beauty of something like a peer treatment support service is that it's pretty flexible. You can kind of you can augment it to meet the needs of different cohorts of individuals within your community as funding comes up. So peer treatment support service does a whole bunch of different stuff. Essentially, we engage through two low threshold engagement mechanisms, our drop-in center and through we do three big community barbecues every week throughout, and then a number of outreach locations as well doing in-reach. And then basically what happens is, you've got a nice low threshold catchment area for people to have that beautiful one-on-one yarning and talking with peers in, and then when somebody's ready to work on their individual health and well-being, we can assign them to an individual peer treatment support service worker who's got similar lived experience as they do. And when I'm say lived experience, I'm encapsulating both lived and living experience. And then the trick with it is that, and we have this really broad scope of practice. So there are those two engagement techniques. And the idea is that no matter what it is that it's your goals, it all comes down to health and well-being. So it's all about the social determinants of health as well as the basic kind of primary health care and linkages and stuff like that. So really broad and diverse scope of practice. The trick, though, as a peer worker is it's not about being an expert in all of these different things. It's about being an expert in finding safe ways to access those things and to help navigate people through them. And so, whether it's legal challenges or care and protection, I want to get my kid back, or whatever it is that's actually that's topical at the moment and people are dealing with in the community. You don't have to be an expert out as a peer treatment support services worker, but you do have to be an expert in providing that really warm linkage to services, support, transport, material aid, stuff like that. And then we do try and have quite a diverse range of different experiences. So if someone rocks in the door and it's not just harm reduction, so it covers drug treatment as well. So whether you want to come in and say, sick of drug use, I want to go to a resi rehab, we've got people on staff who've done that journey. And so we can hook them up with that all the way through to the kind of more normal NSP and harm reduction safer using stuff with appropriate expertise. These are the guiding principles. If you're interested in looking at this, we've formalized a model of care. It's on the Karma website. It goes right into kind of what is a peer at Karma, what's a peer worker, what are these things that we're talking about, lived experience, what do they mean, why do we use the words people who use drugs and people who use drug treatment services. So there's a bunch of kind of stuff that's within that model of care that is just about Karma's particular circumstance. It's all about these four basic principles about accessible services, promoting health and well-being as a positive thing, advocating for human rights, and challenging stigma and discrimination. And then that flows into our approach to healthcare, which is around person-centered care. Yes, everybody says a hospital will say they do person-centered care. They actually, in my humble opinion, a lot of services actually are clinician-centered. And so there's stuff around kind of timely and flexible service provision, and that broad scope of practice, and that low threshold engagement. So the other part is that we build up from community. So all of the people, they've come through the services that we're working within, and so they know the staff as a service user and as a staff member. So we got some funding to do and specifically work with a couple of peer treatment support services on the healthy and creative aging side of things. And it comes out of all the wonderful work that was done at AVIL on the hidden population report, which showed that for people who use drugs, aged care services are really scary and they are really discriminatory. And it's difficult to get access to NSP, HCV treatment, opioid maintenance. It's all problematic. And I think problematic is genuinely the word that you would use to describe it. And so, we tried to do this to try to build some bridges and just to actually start to make some partnerships with aged care services to reduce social isolation and provide pain support and chronic pain support in particular, and then offer like a broad package of services for people. There was a number of different services that we did. The big one was that counselling that was the counselling stuff, transport, and then an art therapy component on top of that case management, identity, peer support stuff. Here's some of the stuff we did in the art therapy. It was really good to see people getting out there and getting involved. And this was one of the favorite parts. We did like some excursions with a counselor, but she wasn't actually doing counseling. She was just doing art, just doing art. And then we showcased it at like an exhibition, which was, quite successful. And then we sold some of that work as we usually do. Counselling was great. Not everybody, we had about 50 participants. Not everybody opted for counselling, but about 13 did. And for them, it was really successful. It was something they really loved doing. The common themes that we found were this fear of being left behind by their loved ones, particularly children who'd moved on with their lives, and that social isolation was overridingly the big thing. Mental health was a big kind of barrier to actually engaging in things like art groups. But if we could get people there by provision of transport and support, then actually we saw that the groups really helped eliminate those mental health challenges that people found. So it was kind of one of these threshold things where you had to kind of provide a pathway for people to engage and be really supportive in engaging and then once you put that in, some people would engage and then it would overcome that issue that they were having. There was a whole bunch of palliative care challenges and barriers that came out of this work, which I don't really have time to go into. You're more than welcome to have a look at these slides. We ended up doing some presentations for palliative care services in the ACT out of the end of this work, and we're now doing some research trying to set up some research with Directions GPs and with the doctors who are involved in the palliative care and geriatric care systems to try and overcome some of these barriers. So I'll give you two examples to finish off with. Nurses filling out risk assessments. If they come across the fact that a person is using drugs, they're unable to provide at-home support to the person. The person actually has to come into the hospital to seek care for palliative care, and that's because of safety concerns. So big barrier there. A lot of discrimination in the background of that one, which we need to kind of sort through and make sure that unions are comfortable and safety is provided for nurses and peer workers can help do that. And of course, what was happening, peers were just too afraid to go into hospital to seek those palliative care. And so it was just exacerbating the systems. We found that another level of issues around accessing and fulfilling the aged care package requirements, linking into providers, doing wills and assigning legal paperwork at the end of life, and then the associated palliative care issues around pain relief and people, professionals not understanding what the actual role of methadone, buprenorphine actually are, that they're not actually, used as pain relief in this circumstance. So some really good discussions happening there. And of course, very important to be diplomatic in order to overcome these challenges and not just state that it's a problem and get angry. And the work continues. So, we're engaged well with palliative care and geriatric care services now and providing support to people at the end of life, all the way through to providing help setting up funerals and things like that, which I think is, really valuable for the community. And I'll leave it there. Thanks very much.
Thanks, Chris. I feel like we've been hearing about this aging cohort for quite a long time. It's just incredible that there's some peer support available for people and advocacy and the work that you guys are doing. I hope we can see more of it in other places as well. In the interests of time, so that we have a bit of time for questions at the end, I'll introduce our next speaker, the incredible Sarah Lord. Many of you will also know Sarah. She probably knows more about pharmacotherapy than anyone else in the country, I would be willing to bet. She's the coordinator of the Pharmacotherapy Advocacy Mediation and Support Service, which most of us know as PAMS in Victoria. She's a long-term harm reduction advocate. She's been in this position for many years and continues to advocate for social justice, peer education, and opioid drug treatment that's tailored to meet the needs of our community. So over to you, Sarah.
Thank you, Ellie. That was lovely and very, very generous. So yeah, I coordinate the PAM service, which is a pharmacotherapy statewide phone-based service in Victoria, and we're very pharmacotherapy specific. So we deal with people who have an opioid dependence, who are either currently receiving pharmacotherapy treatment or wanting to start or restart pharmacotherapy treatment at some point in their lives. So a lot of our work involves finding prescribers for people, finding pharmacies for people, dealing with people's prescribers and or pharmacies when things go awry, so sorting out more collaborative treatment plans. When we're looking for doctors for people, it's really important to get that match right rather than sending just someone to the doctor down the road, or it's really about what treatment does the person want. Is that prescriber going to be able to provide that treatment, and getting that match right? Because if you get that match correct in the beginning, then people are likely to stay in treatment for the longer term. And, I'm telling you stuff you all already know, but that's very much how we work. So we don't just, even though we're a phone-based service and we work right across the whole of Victoria, which is really good. We get lots of calls from people in rural and regional Victoria, as well as the metro areas. But as I said, we actually make appointments for people and then do follow up afterwards. So it's kind of really sort of short-term solution-focused case management in terms of what the PAM service provides. And of course, as we all know, the pharmacotherapy cohort is ageing. And when I look at the NOPSAD data every year, each year the average age of a pharmacotherapy client nationally increases. And there doesn't seem to be a hell of a lot of preparation for an ageing cohort. I think the oldest person that we've had contact us at the PAM service, I think, was actually close to 80. So, and that didn't happen 10, 15 years ago. I think maybe sort of 60, 65 was the oldest. So that when something like that happens, it really drives it home to us that it genuinely is an ageing cohort. And there are many people that we speak to who have been on a pharmacotherapy treatment program for like 20 years, 30 years, 35 years. And so the pharmacotherapy treatment is literally part of someone's life. It's not a short-term thing, as many of us know. Particularly, I think, with methadone is what I seem to have noticed. And, I mean, yes, of course, we need more treatment options, but this is, often quite a lifelong treatment. I think for people who are ageing and on pharmacotherapy, things can get more difficult. Everything can get more difficult as you age. And I think adjusting to change is something. For example, if your prescriber retires and you've got to find another prescriber, if you've had everything, for example, your dose, the amount of take-home doses you get every week, if all of that's been stable and kind of working well, and then your prescriber retires, who's going to take over? Quite often it's not somebody at the same clinic, and you've got to go to a completely other clinic and renegotiate all of this stuff. And we've certainly worked with people who have changed doctors after one doctor's, retired, which is probably one of the biggest problems we're facing in Victoria at the moment. And often they're quite big prescribers with high numbers of patients. But adjusting to all of that is really tricky. I guess one of the good things about aging, like I don't want to make it all completely doom and gloom, But one of the good things is you do kind of, you know more about what works for you. So you can kind of know what you want. It doesn't necessarily mean it's easier to get it, but at least knowing that is a good thing. A lot of people who are older, they know what type of treatment in terms of pharmacotherapy, what works for them, what they want, what dose they wanted, how they wanted. One of the things that can be really difficult is not being able to get enough takeaway doses, distance, travel, mobility to get to prescriber appointments, but particularly to get to the pharmacy. In Victoria, we do have up to 6 takeaway doses a week of methadone, which is great. And there are a lot of longer-term methadone clients who are receiving 6 takeaways. But still, even that one visit to a pharmacy once a week can be difficult if you don't have a car, you're not able to drive. People's ability to work and an income, that can change. Everything kind of changes as you get older, and this pharmacotherapy is kind of runs along with that as well, because it's such a, I guess, an important but quite often daily part of our lives. Other issues that we deal with, prescribers gone away or become unwell themselves, script expires, the pharmacy is not able to dose you. It's all of these sorts of kind of seemingly maybe minor things that can become quite a significant panic. The toll that it takes on somebody who is older of not having a dose is far greater than what it is for that same person 10, 15, 20 years younger. Things take a lot longer. Your body takes longer to repair, and the effects of not having a dose or not having the right dose can be far greater. And I think some of the stuff that Chris pointed out was really, really valid in terms of access to aged care services. One of the things that we found with one of the doctors that had retired in Victoria, there was actually a prescriber who did quite a lot of pharmacotherapy in an aged care service. And it was really hard to find a prescriber for those patients who had been seeing the doctor who retired, because nobody would go into the aged care service. And then we were all of a sudden having to organise transport for people from aged care services to get to a different prescriber simply so they can get their script. And I mean, it just does not seem okay. That's not right. I mean, in many ways, it should be like every other health care that's organised for people who are in aged care services. And of course, stigma and discrimination doesn't go away. It's in every part, but it's when something changes that you really get hit with so much of, when everything's going along and it's all right, it's okay, and then something changes, and then you suddenly sort of can realise how much stigma and discrimination is still there and still affecting so much of kind of who we are, how we are, what we do, where we do it, that sort of thing. So that's, I don't want to take up too much time, but in a bit of a nutshell, that's some of the stuff that we deal with at PAMS. And as I said, I got quite a shock the other day. I had a pharmacotherapy client who told me they were 18, and that is the youngest person I've worked with for a very, very long time. Most people are sort of 48 plus. Many people we work with at PAMS are in their 50s and older. So, yeah, aging cohort, that's us. Myself included.
And me.
I know. Well, that's part of one of the good things of running a peer-based, being involved in a peer-based service, and when it is something, like this aging topic, it's affecting me. I mean, I'm in my late 50s. I hear what everyone says. I feel it as well. That's part of it.
Indeed. Thank you so much, Sarah. Your knowledge is also like outstanding and something that I think we all rely on, not just in Victoria, but often in other places as well. I'll just get everyone to turn their cameras on. We've got a time for a couple of questions, and we've had a lot of comments from people. Chris has to go in a minute, but I did just want to mention one of the comments from a peer worker who said that the model of care that Karma has done, the way that Karma works is their guidebook and their Bible, I think might have been the phrase. No, their guidebook. So that's pretty sorry, oh God, I brought religion into it. Anyway, that's pretty nice. And there've been comments about everybody's experience and the work they've done and how important it is to everyone. And I think it really has been today a testament to the work that all our organizations do, that we have such a broad range of expertise and types of services that are local and meet the needs of our community, and that we're all doing and have been doing sometimes for a long time. Sometimes it's new things, but it's pretty amazing what we're doing as peers in this country. There's a cup, so thank you everybody that for sharing all of that with the people. There's a couple of fairly quick questions I think I can ask on behalf of people that have put them in the Q&A. There was a question for you, Sarah, about whether you have the full list of prescribers in Victoria. I don't know if they were asking you to share it or not, but do you have the list of prescribers in Victoria?
Officially, we did not for many, many years. Finally, about I think 3 years ago, maybe it was sort of during COVID, we actually were officially given access to the names of the new prescribers. Keeping our list updated is an ongoing task. But yes, we do, but I'm sorry, we're not allowed to give it out. It is a privacy and confidentiality thing. And what that goes back to is when the prescribers do the pharmacotherapy training in Victoria, they sign a piece of paper that it says that they agree to let whoever we're one of, I think, there's only 2 phone-based services that are allowed to have the names of the new prescribers, obviously, as well as the Department of Health. Some prescribers refuse to sign that, and we don't know who they are. That is possible. We don't know who in the way that it works in Victoria, any prescriber can script Suboxone for up to, I think it's 10 or 20 people. That's going to change. It can be whatever, but we don't know who they are because they don't have to do any training. But yeah.
Yeah, thank you. I think it's interesting for people to know some of the reasons behind why those decisions are made and whether you agree with them or not. It's interesting and useful to know. Thank you. There's a question there's a few questions for Dr. Tim. One of the ones I've got is actually also a simple question. Dr. Tim, is Rita available on prescription from GPs?
No, still in phase 2 trials, but I guess the way it's going, probably down the track. Yeah.
It sounds like a few people are getting it, and quite a few people on the line were talking about some of their experience.
Oh, super popular. Yeah.
So there was another interesting question for you asking whether you're seeing lateral violence between people who use drugs and peptide users. Can you speak to that at all?
Yeah, look, I think like people who use enhancement drugs, and so that includes peptides, have often had there's been a really tricky relationship between health care providers as well as any health services that goes back like 40 or 50 years. I think at NSPs, there is that othering that can sometimes happen where, people think that there's a difference between some types of people who use drugs and others, or that, yeah, I guess for us in Queensland, I guess the way we try and manage that or bring that together is bringing all communities in and reminding everyone that NSPs are for everyone, not just for particular types of people. And we're not interested in really what types of drugs people use. The only reason that it is like relevant is so that particular health conversations and resources can be distributed. And I guess one way that that's been done well is sort of those elements of cultural safety. So being able to hang up posters or present resources like we did with Roid Check, like we do with Steroid Connect, to make people feel seen and heard. And I guess as that sort of happens, you can bring communities together, and then there's all that relational work that happens at the frontline service level. So I think it it's a process, and I know that some communities can other each other and sometimes be challenging to work with, but really, really appreciative of the patience that everyone's having.
I think it's really important. We're definitely seeing changes in the way that different people are accessing NSP over time, and we're all seeing more people using performance and image enhancing drugs, lots more methamphetamine users than there used to be. So it's important for us to be inclusive across the country, I think. Thank you. I think we've kind of run out of time, so I don't think I have any more questions that we need to answer now, but I'm sure all of the panelists would be open to hearing from people. We can also try and get your questions answered outside of this session. But I'd like to thank all of our panelists for sharing their experience today, for your excellent presentations and your amazing work that you're all doing. Thank you everyone that joined us to watch the presentations. Let us know if you have any questions for the panelists, and we will definitely try and get them answered for you or connect you with people. So thanks all. Another excellent, excellent showcase of our community. You're rock.
Thanks, everyone.
Thank you, Ellie. Thank you, everyone.